Going into pre-roll. 3, 2, 1.
Welcome to Home Care Connection. I'm Harry Snyder. Here today with Holly Citro, a registered nurse and hospital liaison or transitional care coordinator for the Rutland Area Visiting Nurse Association and Hospice. Welcome to the show, Holly.
Thank you.
We're going to talk today about what happens after you've been in the hospital as a patient, and now that it's time to go home and you're being discharged, we're going to talk about that process of being discharged and going home. It's good to be leaving the hospital. It means you're getting better. Hospital stays are shorter than they've ever been, or certainly much shorter than they used to be. So often patients who've been hospitalized for an injury, illness, or chronic condition receive follow-up medical care to recover at home. Receiving help at home can be the best approach to what we call post-acute recuperation following discharge from a hospital. Home care helps minimize complications and helps patients recover as quickly as possible and regain independence and become as self-sufficient as possible in the comfort of their own homes. So, perhaps we can just sort of talk about, all right, so let's say that a patient who's had some time in the hospital because of surgery or illness or whatever the reason was is now ready to be discharged. Who are the people involved in discharge planning at the hospital and I guess with the VNA, and what are their roles?
Every hospital has staff, and they vary by title. At Rutland Regional, they're called case managers. At Dartmouth, they're called clinical resource coordinators. But it's an assigned nurse, and they follow along with their physician lines. And the role of these people is both to coordinate care while the person's in the hospital, but then also to look at their needs post-hospitalization. So they do a very comprehensive review of their services, their supports at home, their needs post-discharge. And often they are the initial people to identify that it would be helpful for somebody to have home care. And that being said, people can also have referrals made by the physical therapist who's working with them, say at the hospital, or the wound care specialist, social workers, the nurse on the floor taking care of the patient, the physician taking care of the patient. So it can come from a variety of sources. The patients themselves or family members will often ask for some help after discharge. But basically, it's the case manager who is the liaison between the VNA liaison. And we have an office at our agency called the Intake and Referral Office, and we are involved with helping to coordinate that request and making it turn into a referral for home care. So once we get the name and we get some background information on this patient, we will do a little bit of research to see what their needs are, whether or not they qualify for home care, both by their insurance or lack thereof, and by their needs. And if we feel that home care is appropriate, we would then further along the referral process. Okay. And as part of that, we try to meet with them in the hospital if time allows, and they're available and we're available, just to discuss what it is that we hope to get out of this relationship. And from there, the referral gets generated. The physician has to order the home care. So once the physician has ordered home care, the referral gets over to our office and we go from there.
All right, so just to sort of recap a little bit, whether it is a case manager or what do you call the other clinical
resource coordinator.
Okay, so that person is actually somebody who's already familiar with what the medical needs of that patient are, even while they're already in the hospital.
Correct.
And then they coordinate with the physician to determine options for post, like after the hospital stay.
Yes.
Okay.
So, and often patients tend to be in and out of the hospital, so they become better and better known by both us and the hospital staff, and so it becomes easier to know just exactly what their supports are, what their weaknesses and strengths are, and just how they would benefit from home care post-hospitalization.
Okay.
So it's sort of a fluid, ongoing process.
So the case managers who work in the hospital, regardless, and I'll say, we're talking about the hospitals that Ravna works with.
Correct.
But really, this is probably true, even if the titles are different, this is probably true in any hospital, right?
Basically, I think there may be some hospitals that don't have this program, but
Yeah.
most have some sort of a discharge planner, case manager.
Yeah.
It may be a nurse, it may be a social worker, but most hospitals have somebody to help get that process in place.
Right, and they basically are working with the patient to identify what their likely needs would be after discharge, of which home care could certainly be one of those.
One of many options,
Right.
yes. Yeah.
Okay.
Yeah.
All right, so when, from your experience, when does a physician, I guess, say, sort of consider home care as a post-hospitalization option?
I think it matters what the patient's needs will be after they're in the hospital. And nowadays, as everybody knows, hospital stays are very short.
Yeah.
Hospitals tend to be more like intensive care units of old. People have to be acutely ill to be in the hospital. They receive treatment for that acute illness. Once they are stabilized and they're progressing at a stable rate, it is time for them to leave. And that's due to many things in our healthcare system nowadays.
Right.
So often these people are ready to no longer be in the hospital, but they are not ready to continue to be independent. So the physician will look at what their needs are. Say they're recovering from a very critical illness.
Yep.
They're better, they're not well.
Yep.
And so they would like to have a nurse come to the house to check on them, check their medications, listen to their heart and lungs, check their blood pressure, et cetera, and see how they're coming along. The other thing that happens is with people with illnesses is often they're quite deconditioned, they're weak,
Yep.
they have trouble climbing stairs, for instance, they get short of breath with any activity. So that's where therapy can come in to help to actually go to the house and work with people on therapy. So those are the biggies. And then, there are the obvious things, the people who have broken hips, people
Sure.
who have a stroke, somebody who is a new diabetic, for instance, who has been ill and is not really going to be able to be out and about easily, quickly, that's a great opportunity for the visiting nurses to get in and start doing some
Right.
teaching.
Right. Right.
So really, I think home care is two-pronged. It's care,
Yeah.
checking vital signs, checking medications, working with a person who's had surgery, with therapy, et cetera, and it's also teaching. And we do
Yeah.
lots and lots of teaching at home.
Yep.
And again, if somebody's in the hospital for 2 days, the nurses at the hospital have very limited opportunities to work with them.
Absolutely.
So that's where we would come in to take over that role. We work really closely with the hospital. We know we can find out what's happened already, and then we can carry it over to when they come home. So keep it sort of somewhat seamless.
Well, and that's really, I think, an important point, is it not? That the fact that, the physician and the discharge planners are really working together to sort of take a look at what the patient's needs are, obviously the reason why the patient was hospitalized. And again, I think the example you pointed out, like a hip replacement or something like that, it's a pretty obvious that when I get out, I'm going to need therapy. And because hip replacement surgery is a fairly major, even if it's done differently, it's still a fairly major operation.
Right.
The likelihood is that I'm going to need therapy both in my home and then even later in an outpatient setting. There really is the concept of that continuity of care, of carrying that care over, or maybe coordinated care, I think is what you said. The fact that, here are this patient's needs in the hospital, what are they going to need immediately after they get out of the hospital in order to be able to get back to some level of functioning, or even get back to the same level of functioning than before they came in. That is an important part of both what the physician looks at and also the work that the discharge planners do in evaluating home care.
Right. And as I had mentioned before, the variety of options, some patients, after they've been in the hospital, are not able to go home. They perhaps live alone, they don't have enough support,
Yeah.
they're not safe at home.
Yeah.
For those people, there may be an interim stay, which might be a nursing home with rehab, or the acute rehab setting, where they would get 24-hour care, but not at the same level as the acute care in the hospital. They would continue to get therapy. When those people come home, often, almost always, they would then drop down to having the visiting nurses follow them at home
Right.
for a time until they are independent or able to be, back to their prior level of function.
Right.
So that's, the other thing that happens is often with our joint replacement patients, it's very difficult for them to get into a car when they're first home.
Absolutely.
So they have therapy at home, the therapist works with them, but the goal with that always is to get them into the outpatient setting where they have fancy machines and things that we
Yep.
just don't have in the home.
Sure.
So there's always a continuum going on, and again, it's a great communication among all the different providers
Yeah.
to make sure that this person gets what they need.
Yeah,
So,
and I
yeah.
do. I think that's really important because I think at the heart of everything that you're talking about is the idea of what's in the best interest of the patient.
Exactly.
And sometimes that is a home care referral. So if I were, say for the sake of argument, in the hospital, and knowing that my discharge was just about to come up, what kinds of information would I ask for before I leave the hospital with respect to what options are open to me?
Well, are you talking about the care after hospitalization?
Yeah.
Oh, well, the case manager would be meeting with you to say, and just like in home care, when we admit someone to home care, the thing that we think about at the first visit is discharge from home
Yes.
care.
Yep.
Because our goal is to have somebody be back in the community.
Right.
Same thing with the hospital. When someone is admitted to the hospital, right from the get-go, they talk about discharge. And
Makes
so the
sense.
case manager will have been talking with you every day about, you're getting better, it looks like you're getting ready to go home. And at some point, they'll identify either from someone, a therapist saying to them, Harry really is not doing great on the stairs, or weak or something, or the nurse will say, he's just not catching on, he has a new diagnosis of
Yeah.
whatever, congestive heart failure, he just doesn't seem to understand it.
Yep.
At that point, it'll be identified that you need some further care.
Yeah.
And then they would also look at what level of care you need. And again, as I had said earlier, if you live alone and you're not safe to go home alone, then they would need to look at some other interim situation for you
Sure.
until you are able.
Okay.
And also, I should say, this is voluntary on the patient.
Patient side,
They
absolutely.
can say yes or no.
Right. Right.
We live in a free country. People
Yes.
can make their own choices, be they good or bad.
Right.
And so,
And it is a decision that everybody has to make, but I mean, but home care is, when home care is a prescribed follow-up to a hospitalization, again, I mean, there is no actual downside to home care. I mean, whether or not I have home care
Right.
is a separate issue.
Exactly.
But no matter
Right.
what, the intent and the goal of it would be sort of my quickest return back to a level of functionality.
Exactly. And most people are very receptive to home care, find it a very positive experience. It does help them recover quicker.
Yep.
Complications get picked up faster, and a lot of times, again, because the hospital stay is so short, people may come home with some misconceptions. The other thing that happens is people are very ill in the hospital typically,
Yeah.
and overwhelmed
Yes.
with many, many things. And even though it's time for them to go home, they still feel very nervous and overwhelmed. And it's reassuring to know that the nurse or the therapist will be coming to visit. And
No question.
And the other thing that we do is we have a close communication with the patient's physicians. So any sorts of untoward things can get quickly reported to the physician by one of our nurses or therapists. And so I think it's